Okay, let's finish up our last two disorders for the class. First one we're going to talk about is prostate cancer. Prostate cancer is going to be cancer, obviously, of the prostate being this little gland that resides right beneath the bladder in males. This is the problem with this is it has impacts on both reproductive and urinary control because the bladder has to pass the urethra through. We also have the other vas deferens are going to be coming in from the testes as well. So the problem with this is the kind of counterintuitive nature of the prostate gland cancers is that this is a very common cause of male cancer death. And we have this effect that most of the time you don't really have to worry about it. So like, how can those things be true at the same time? And it mostly comes down to the fact that they are very, 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 very common cancers. You're going to see prostatic hyperplasia at least, which is like overgrowth of the prostate, in nearly all geriatric males. So prostate cancer being a lifetime occurrence of around 16%, that's a really common cancer. So if you say most of these are not going to be a big deal, most of these are not concerning, but there's just so many of them, that still causes this to be a very, very common cause of mortality. When we're talking about causes of prostate cancer, we mostly don't know. This is another one of these idiopathic disorders. Probably has something to do with hormonal control, we think. So things like diet and obesity have an impact on hormonal control because of things like the aromatase that we've talked about, as well as like diet considerations. So this might be something to do with this. Mostly what we care about with prostate is getting it detected in the first place. So we use the prostate screening test and a DRE, a digital rectal exam. The prostate specific antigen test is this PSA test. So basically they're going to take a blood sample from you and they're going to look and see what amount of this antigen that commonly is associated with prostate cancer do you have. So this is the problem with this is like you could get a PSA level that was very, very, very high and very, very concerning, right? This really just means that you have a lot of prostate kind of inflammation more than it is actual a signal that there's a lot of cancer, right? So there's a lot of prostate antigens in the blood, but some things like riding a bike, right? Well, that's going to put a lot of pressure right down here on the prostate. So that's one of the things that is going to stimulate a lot of prostate antigens to be released into the bloodstream. So like putting pressure on that itself isn't a surprise that you're going to have a lot of PSA test. Then once you have a high PSA test, then sometimes you'll go in and get another screening test, a digital rectal exam. Digit here means finger. So they're actually going to use a finger that passes in through the rectum, and they're going to feel the prostate. The prostate normally is going to be pretty squishy, but if it starts to harden and get kind of bouncy, kind of like a rubber ball instead of like a bouncy, malleable ball, well, then that's a clear sign that there's a little bit more hyperplasia. There's a little bit more cell growth in there. Maybe that's a thing that we now need to move to the next level of screening. The reason why we have a lot of layers of this screening, I want you to go watch this video on your own. It's really good. Basically, the gist of the video that I want you to get out of it is that, hey, just because somebody has cancer doesn't mean that we should treat them for that cancer. And hey, just because we can test somebody for cancer doesn't mean that testing them for cancer is actually a benefit. So it's a pretty nice. Prostate cancer is a very, very slow growing cancer. It's pretty benign. So that leads to this kind of complication in treating and managing prostate cancer. You can test every single person for prostate cancer and you'll find a lot of prostate cancer, but the actual impact on people's lives is going to be pretty moderate unless you discover a prostate cancer that's really rapidly growing, but those are not very common. So if you do end up having a need for a biopsy, so this is basically you're looking at the prostate, so this is going to be like the urethra that passes through it. What they'll do is basically show us a scatter shot of biopsies. So they're going to use a needle and aspirate portions of this prostate, pulling out sections of this, And what they're looking for is they're looking for like sections of this prostate biopsy that are kind of concerning, like these kind of like weird growths. You're looking for poorly arranged cells, cells that are like going through rapid division, cells that are starting to see a lot of metaplastic change. That's what we're looking for as a concerning prostate result. If you have a high PSA and you have a kind of stiff DRE exam and you find something that's worrisome on a prostate biopsy, that's now kind of, you actually maybe still don't get tested. You still don't get treated. Go watch this video. It actually shows this kind of surgical procedure. I actually think it's really interesting how they're using an ultrasound wand. That's what's in this person's left hand. And they're using that ultrasound to guide this biopsy needle in their right hand. So what you're looking at here is, here's the anus. So the ultrasound is perianal. So they're actually using the access that the anus gives to listen to the inside and basically find out where they are inside of that prostate, so they can know they can drill into that area, right, to get those biopsies. So the problem with this is, even if you do find a worrisome result, most of the time the advice is going to be wait and see, because we're trying to avoid giving someone chemotherapy just because they have prostate cancer isn't necessarily a great thing, because that prostate cancer is generally not that risky. So over-treatment is really more of the concern. So this is kind of your standard cancer stuff. The only thing being screening is quite weird and quite odd how you would use something like that for prostate cancer. The last disorder we're going to talk about for the class is PCOS, is polycystic ovarian syndrome. This is again, very, very common thing. It's also very historically underdiagnosed, again, because of sexism. This is mostly an endocrine disorder. So this has both to do with things like sugar control as well as androgen control coming out of the ovaries. So this ends up causing you to have a relatively high concentration of the androgens, particularly the androgen that we care a lot about is testosterone. And so that testosterone ends up causing a lot of odd development. We develop a follicle, but we never actually kick that follicle out. So we end up getting these really, really big follicles that have never actually ovulated, and now they start to actually impair like normal function. So this is why it's a polycystic, lots of big cysts in the ovaries. So let's talk about how this works. All right. So just a general reminder on like tissues, right? So we have our hypothalamus. Our hypothalamus communicates with our anterior pituitary. The anterior pituitary communicates with both the cells in the follicle inside the ovary, so like an ovarian follicle. The ovarian follicle, if you remember a little bit from 1810, is mixed between a theca cell and a cell called a granulosa cell. These granulosa and theca cells are the ones that actually produce those androgens. And we have another system here that actually matters, and it's our old friend, the pancreas. So those are all of our tissues. Let's talk about our hormones. The hypothalamus, let's use red because it stimulates. The hypothalamus produces, obviously, gonadotropin-releasing hormone. Gonadotropin-releasing hormone stimulates the anterior pituitary to make its own, and it makes things like luteinizing hormone, as well as follicle-stimulating hormone. Follicle-stimulating hormone being the thing that causes a lot of follicular growth, luteinizing hormone being the one that causes ovulation. So what we end up doing is this luteinizing hormone is the one that stimulates the theca cell. In response, theca cells start making androgens. The one we care a lot about is testosterone. FSH is actually more directly stimulation on granulosa cells, and so granulosa cells start producing their own hormone, estradiol. Right, estrogens. So what this means is someone with this syndrome, and then the other thing that gets made out of this is, of course, going to be insulin. So this is kind of a which one starts it But if we were talking about a dysregulated reproductive system causing pancreatic issues, or if we're talking about pancreatic issues causing a dysregulated reproductive system issues, either of these can be the start for it. But what ends up happening is we start to see instead of the normal pathway, so normally we see a rise and decline in gonadotropin releasing hormone, the pathological situation, for reasons that are mostly idiopathic, we start to see an increase in frequency. So a frequency increase. That frequency increase means that we start producing more gonadotropin releasing hormone, and this gonadotropin releasing hormone stimulates things like FSH, and it stimulates things like LH. But what ends up happening is that this stimulation gets to be a little bit bigger in the LH side of things. So we end up stimulating luteinizing hormone production more than we stimulate FSH production. This means that theca cells get a ton of stimulation, and granulosa cells get a little bit of stimulation. So they still have some rise. So we have this kind of like odd effect that there's greater effect on this androgen side of things. This estradiol that starts to rise now leads to a modification of the way, like estradiol's effects, of course, are to inhibit GnRH, inhibit the release of hormones out of the anterior pituitary. But the problem ends up being that we never end up actually getting a consistent signal because of this frequency in GnRH release. So we start to dysregulate how this is controlled. We see these pulses get too big and too quick, and then we end up never really getting enough estradiol, so it can't bring this hypothalamus in the anterior pituitary back under control. So we start to have really high levels of these. Notably, androgens being a big problem in this. Androgens stimulate something called insulin resistance. So there's this effect that if I have a bunch of testosterone, right, and I have a bunch of testosterone because of the large amount of stimulation to theca cells, this androgens itself is going to cause insulin resistance. In this insulin resistance, we've seen something similar in this. This is mostly very, very similar to something like a type 2 diabetes mellitus, right? This insulin resistance then is basically a giant stimulus to make more insulin. So we start saying, hey, the insulin that we're making isn't enough, so we start producing more insulin. Well, insulin is one of the reasons why the theca cells get overstimulated, because insulin actually acts on theca cells as well. And it stimulates these theca cells even more. So there's like this other like pathological stimulation that comes in. That's part of the reason that we see a big increase in theca cells, but not so much in granulosa. So now the theca cell gets stimulated more. There's additional androgen stimulation. There's additional insulin resistance. There's additional insulin production, which causes additional theca stimulation. Right? This is the end result being common symptoms that show up is you have hyperandrogenism, right? You have a lot of androgen hormone. You don't have that much estradiol. So what we end up doing is you become infertile because now all of a sudden this GnRH, as pulse of GnRH, doesn't actually, like this short time span in this, doesn't give a follicle long enough to develop. It's too short for follicular development. It doesn't give the follicle enough time to grow, development. So now all of a sudden we can't develop a follicle, we can't ovulate that appropriately, the egg can't be generated. And we now develop something very akin to type 2 diabetes. So this kind of interplay between this, mostly at the fault of the theca cells. So this hyperandrogenism causes a bunch of things like acne, causes body odor, causes this kind of thing, all of the effects that testosterone that we're familiar with from puberty. but it also causes hirsutism. Hirsutism is just lots of hair growth, particularly hirsutism of arms and legs and face, right? The kind of thing that you see commonly expressed in males. Now, this means that females do end up start growing hair in lots and lots of places. I remember hirsutism because it's like the person is wearing a hair suit. Hirsutism, that's the way that I link that in my head. Right. So this is very common. You end up having infertility issues because you don't have enough time for that follicle to develop. You develop insulin resistance and all of these negative side effects. So it's kind of a chicken and the eggs thing, right? So is this caused originally by androgen dysregulation that then makes you insulin regulation worse? Or do you have somebody that is a type 2 diabetic that ends up making a bunch of insulin that then stimulates those theca cells that dysregulates what's going on in the ovaries? So it's probably both. There's probably individuals that are in both of these camps. So what this is dysregulation of androgens and insulins. So we try and get those back under control by doing things like weight loss. One of the things that associated with this is if you have a lot of adipose tissue, obviously that messes with aromatase, so it starts to change that. We can try and get the diabetes under control using common diabetic management, and there is some degree of people experimenting with hormonal control, things like progesterone pills, that kind of thing, to try and bring this back under control. But it's pretty difficult to manage without taking both the pancreatic side and the ovarian side into thought. And that's all we're going to do. So I will see everybody on Friday.